Welcome back, everybody, to the OPT Network. The month of February is Heart Month. There is so much information that we need to know about our hearts. And here's what the statistics say. 1 in 4 women in their lifetime will die from a heart attack. Here to talk about what we need to know and understand is Dr. Reymond Meadaa. He has been a cardiologist for well over 2 decades, and he happens to be my cardiologist as well. So we welcome him back to the show. Dr. Meadaa, good morning and welcome back.
Good morning. Thank you so much for the invitation.
So let's start with what every person needs to know, because we know that not only is heart disease the #1 killer of women, it's the #1 killer of men as well. So let's help us to understand the intricacies of the heart and its importance.
Great. Well, I'll tell you what, before one very important issue that I really find it from my practice and from my experience is that the more you educate your patient, the more they understand about their disease, the better they're going to be able to manage their disease. So before we start talking about the heart disease, let's see what we're talking about.
Okay.
So this is in here, we have a heart model. And you see the heart has 4 chambers.
Okay.
2 on top, 2 at the bottom. The heart has 2 sides, the left side and the right side. And the heart has 4 components. It's got the muscle. It's got the different valves, which is the structure that separate the different chambers. It's got the electricity that's responsible for beating of the heart and all that. And it has, in simple terms, plumbing. It has the coronary arteries. And you can see in here, we have 3 main arteries. One goes on the left side, one goes straight down, and one goes on the right side. So when we talk about heart disease that runs in family, we're talking about the plumbing of the heart. The coronary artery disease, or the fancy name is atherosclerosis, or the old terminology, hardening of the arteries. So starting with that, I think we're gonna take the next level. So out of the heart, you have the pipe, the blood gets pumped into the main line. That's called the aorta.
Okay.
And you see in here, you have the pipes that go into the carotid arteries. Those are the carotid arteries that supply the brain. And those are the ones they clog up and they cause strokes. Then
Okay, so let's stop there. So the carotid arteries, when they clog up, they're going to the brain. Are those the ones that are going to be in our neck? Are these going to lead up to the neck?
Yes, and if we can zoom in on the poster in there, and you can see in here, this is the heart, and then you have the aorta that's coming up there. You have big pipes coming in the right arm and the left arm, and then you have the carotid arteries, and you see it comes halfway to around the jaw area and branch into 2 main arteries. One goes to the brain and one goes to the face. So clogging up of the carotid arteries, that's what causes stroke. Now, after that, the pipe turns around, goes in your chest, in your belly, and it goes all the way to your feet. And clogging up of all those pipes, that's what causes PAD, or peripheral vascular disease. That's when people have sores and ulcers, they end up losing their feet, especially diabetic.
Wow.
All right. Now, so we have 3 main vascular beds. We have the heart, we have the carotid arteries, and we have the peripheral vascular bed. Now, our heart pushes the blood to your feet. Then the blood has to come somehow to the heart. But we don't have a heart in our feet to push the blood back to the heart. So how does that happen? The same red tree that we see in here, we have a matching tree. Those are the veins.
Okay.
And the veins are structured in a way they have one-direction valves. And when we take steps, the muscle will squeeze the vein, it opens the valve, it pushes the blood towards the heart, and the valve closes, preventing the blood from going backwards.
Wow.
But as we get older, as we gain weight, as we stand a lot in certain jobs or sit a lot, and especially ladies, when they have pregnancy, they tend to damage those veins. So those veins become like sausage.
Like sausage?
Yes, they become wide, So the valve at this point, when it closes, it does not seal, so the blood leaks back. Putting more pressure on your vein, that's where people start to see varicose vein, and with time you start to see swelling of the legs, and eventually, if you don't treat it, it can cause sores. And actually, most of the sores on the legs are caused because of venous insufficiency, which is leaking of the veins.
Okay, so here's a question. With this diagram, if your blood is not necessarily doing what it's supposed to do, how would you know? What would be your symptoms?
All right. Well, I'll tell you what. I think that's a great question, by the way. Not everybody, now you know we're going to be talking about all those risk factors for this thing. But the first thing that you really need to start by knowing what your risk profile.
Okay.
So you need to talk with your doctor, you need to have an exam, you need to have some basic blood work. And by taking a good exam and good history, then you will be able to stratify people in low risk, moderate risk, and high risk. And it depends on your risk profile. That's how we decide how far we're going to go as far as testing. Now, there's something that comes on top of that. If you have any symptoms, that need to be addressed. But if you don't have any symptom, a good place to start is with your primary care physician, get a good exam and a good history and physical and good blood work at the beginning, and then you can take it from there.
Okay, so the reason why I ask that is because in the last year, 1 to 3 years, I know people personally, women that have had either a heart attack or a stroke, younger women who did not have high blood pressure, appeared not to be symptomatic, and so had no clue as to why they had a stroke. And one friend had a stroke that was, for all intents and purposes, it should have been catastrophic because it was on the brain.
All right. That's also good. So let's back up a little bit to the same diagram that we were talking about. See, if you look at all those, and I said, we're going to use very simple terms so everybody will understand that.
Absolutely.
If you look at those vascular system, it is exactly like the plumbing of your house. And look, our bodies are exactly like our houses. The longer we keep our houses, the more problem we're going to have with them. And the longer we keep our bodies, we're going to have problem with them.
And we need to maintenance them.
And so, and you have a house, of course.
Okay.
And you're a good housekeeper?
Eh.
Good. Did you have any problem with your plumbing so far?
I did. I did.
Well, that's with a good housekeeper.
Right.
So if you leave your house, if you keep your house for 20 years, you're going to have problems.
That's right.
If you didn't take care of the maintenance stuff, probably you would have problem 10 years ago.
Right.
All right. So all those pipes, it makes sense. Whatever happened to one of them, it's going to happen to the rest of them.
Oh, wow. Really?
Yes. So as a general rule, if somebody has a heart attack, you're at risk of having stroke and PAD, and vice versa. Now, there's 7 things, we call them risk factors. And
7 things?
Yes, and those are, and I hope everybody will really go through that exercise.
Okay, hold that thought, because
Yes.
this is important.
Sure.
We've got to take a quick break here, but when we come back, we want everybody to make sure that you stay locked into this conversation, because oftentimes there are risk factors that we ignore or don't notice. Stay on point. We're back with more right after this. We're talking about what every single person, both male and female, needs to know, but most importantly, needs to understand about their heart health. Our guest this morning is Dr. Reymond Meadaa, and he is a cardiologist. He's been practicing for well over 2 decades, and he really understands how to treat each patient individually. And Dr. Meadaa, before we went to break, you were talking about those 7 risk factors.
Yes.
Okay, what are they?
All right. Well, as I said, with all the vascular system, as a general rule, we said if you have a heart attack or you have heart disease, that you're at risk of having carotid disease and peripheral vascular disease and vice versa. So the risk factors are, number 1, men over the age of 45, ladies over the age of 55.
Okay.
High blood pressure. diabetes, high cholesterol, smoking, heavy drinking, and strong family history of heart disease. All right. So there is a couple things we need to discuss about those risk factors. Well, number one, when you look at all those 7 risk factors, there is stuff that you cannot change. You cannot change your age. You cannot change your gender. You cannot change your family. And you cannot cure high blood pressure, but you can treat it. You cannot cure diabetes, but you can treat it. And you cannot cure cholesterol, but you can treat it. The only 2 that really you can eliminate completely are smoking and drinking. So this is a good start for that. The other thing about the risk factors, the high cholesterol. And the cholesterol, there's a lot of numbers, all right? But what you need to understand is there's the 2 kinds of cholesterol, the good cholesterol and the bad cholesterol. And there is published guidelines. And those published guidelines are based on the same risk profile that we talked about at the beginning.
Okay.
So for somebody who has heart disease, somebody who has stroke, or somebody who has diabetes, they are the very high risk group. And those, their bad cholesterol, or what we call it LDL.
Okay.
It should be less than 100 and preferably less than 70. For people who have 2 or more of the risk factors, their bad cholesterol should be less than 130, and if we can, we should go for less than 100.
But those numbers are so stringent, and most people will not be in those numbers.
Well, not if you address that with your physician and see, because now there's really a lot of medication and we can bring it down. Actually, we're bringing the bad cholesterol now to a very low level. But back on there's a lot of, and I get that in the office a lot.
Right.
A lot of patients, they come in, they say they saw on TV that cholesterol medicine is not good for you and they had a heart attack, so they stopped it. All medicine.
On their own.
On their own. All medicine are poison.
All medicines are poison.
That's what they are. All medicine, and you should not take a medicine unless if you need to ask your physician 2 questions. And if you don't have good answer for both of them, don't take the medicine.
Let's talk about what those 2 questions are.
Number 1 is why you're giving me this medicine, and you need to have a good reason. And number 2, for how long I'm going to be on the medicine. I cannot tell you how many times we have patients that were started on medicine, and then they moved or changed, and they stayed on medicine for a long time. So always, the less medicine you take, the better off you are.
So let me ask you this. So if you're a person that has high cholesterol, the bad cholesterol that we know will create problems with either your heart or your carotid arteries, or even your veins at the bottom. So are those people, if they get that down through medicine and start to eat a better diet, can they get off of it?
Most likely not.
Okay.
Because...
So that's forever then? You'd be taking it forever?
Yes, most likely, because even if you do everything by the book and you eat healthy, you can bring your cholesterol down by 10 to 15%, even if you live by the book. All right? So if you take somebody with a bad cholesterol of 200, for example, even if you do everything right, you're going to bring it by, I'm going to give you the max, you're going to bring it down by 30 points. So your bad cholesterol 170 is too high. So those patients need to be on cholesterol medicine. So cholesterol medicine is very effective. And at the beginning, we thought that taking those cholesterol medicine, it helped reduce the plaque burden in the arteries.
The plaque burden.
Which is the plaque buildup in the artery. But that did not pan out. But what it did, it made that plaque more stable. So that plaque does not rupture and cause a heart attack.
So it doesn't move.
It does not rupture, which is the whole underlying cause of having heart attack. So cholesterol medicine are great, especially if you're diabetic, if you have heart disease, if you have peripheral vascular disease, or if you have carotid disease. You need to be on that.
Okay. So let's stay with cholesterol, because cholesterol doesn't hurt. So if you have high cholesterol and you hadn't checked, then you really could be in danger.
Absolutely.
All right. So what do people in the age group that you talked about, men over the age of 40 or 45, and women over the age of 55, what kind of conversation should they have with their primary care doctor about their blood work?
I really think this is pretty much a basic blood work that all the primary care physicians do. I mean, the basic blood work you do for the CBC, which is check for anemia, and you do the chemistry, which check for your kidney function, liver function, and the cholesterol pretty much is standard for adults. So starting with that and talking with your primary care physician, that's going to be the beginning point. By the way, just we talked about those risk factors.
Right.
Which one do you think is the worst one to have, by the way?
Family history.
Absolutely. So that by itself, if you have a strong family history, especially female, especially
Right.
ladies, and
Right.
you have to be very aggressive. And most of the time, those patients will have some problem with cholesterol, so you have to check for that.
And there's nothing really you can do about that, about your genetics or your genealogy.
Not yet.
Not yet.
Not yet.
And so for women especially that may not exhibit the typical signs of heart disease, what do we say to them that may not even know that they are in that risk category? Because now we're finding, I'm meeting more and more women that have had heart attacks. Well, some of the risk factors they did have, but some of the women didn't have high blood pressure, or maybe they didn't know about their cholesterol.
So that's exactly, you said that right. Some of them, maybe they didn't know they have those
Right.
risk factors. So it goes back to the same thing. You need to get a good physician, primary care physician that you trust, and you discuss these risk factors and then go from there. And those patients that they have premature heart disease, that means heart disease at young age, they need to be, of course, addressed. Maybe you need to have a special attention, do a stress test or an echocardiogram, which is a sonogram, to make sure that everything is okay.
Mm-hmm. And then there are the other contingent of women who maybe were born with a heart defect that never presented itself until they get older. What do we say to those women about understanding what's going on with the heart? I mean, we can't see our heart. So we just assume that it's okay.
Well, I'll tell you what, this is a different topic now. So when we're talking about congenital heart disease, most of the time we're talking about some holes between the two sides of the heart or some genetic problem. Most of those patients, when in nursery, now they screen for a lot of these things. So the pediatrician and the neonatologist, they will screen. If they hear a murmur, they will order an echo. And sometimes those murmurs are innocent. And the kids will outgrow those but the main thing is going to come back is just to have good medical follow-up with the pediatrician and good attention to the symptoms. So if a child is having problem with fatigue, having problem with chest pain, turn blue when he exercises, those are the signs that maybe there's some congenital problems.
All right, very good. Let's take a break here, but when we come back, we're going to talk about what we all need to know about asking the right questions and protecting our heart health. Stay on point. We're back after this. Welcome back, everybody, to the OPT Network. The month of February is Heart Month. Sadly, we only really talk about heart health and heart disease. We really amplify it in February, but it's something, Dr. Meadaa, that we really need to talk about every month of the year because it is affecting so many people.
Absolutely.
A lot of people, especially women with the symptoms, really get confused. Let's talk about the symptoms and what people need to connect with because it's the body's way of saying something's not right.
Yes. Listen, as far as our heart is our body is very complicated. And really we think that we know everything, but we don't know a lot of things. So every once in a while you'll get a weird symptom, all right? And we get worried about it. I think what I tell my patients, like having an episode and it passes, just pay attention to that. But the problem and the difficulty, if that happens again, that means there is a problem. So
when you say weird something weird? I mean, just give me an example.
And an
of
example,
something
a patient will come and say, well, I felt something funny in my chest. I cannot explain it. I ate something, did not agree with me, whatever. So don't write it off. Just say, okay, we're going to keep an eye on that. But if that happens, and if it gets worse, or if it gets more reproducible, then you have a problem. So the way we're going to talk about, as far as the heart, per se. So the most common thing that you hear about the heart is one of two main symptoms, either chest pain or some shortness of breath and getting tired when you do things. That suggests that there's not enough blood going to the heart. That's why you get chest pain, and that's why you get out of breath. But there is a lot of symptoms that sometimes it really does not present itself right away.
Right.
So the main thing, whenever you have something like symptom, pay attention to what brings that on. So for example, for chest pain, is it with exertion? And the typical pain for the heart is normally with exertion and goes away when you rest. Is there any associating symptoms?
What does that mean?
Associating symptom that when you get the chest pain, do you feel short of breath at the same time? Do you feel nauseated? Do you break out in sweat? Do you get flushed? And all these things. And the last thing is the radiation of the pain.
The radiation?
Yes. Sometimes people will have chest pain till it radiates down my left arm, down my right arm. It goes to the back, or it goes between my shoulder blade and all. So all these things.
And a lot of people call that gas.
Well, it could be, but it could be the heart. So not every chest pain is heart-related.
Right.
But we always worry about the heart because heart is dangerous. So when you make sure the heart is okay with the proper testing, then you have all the time to do the workup to see what's going on. Mm-hmm. So if somebody come in with chest pain, the first thing, or shortness of breath, or fatigue, just feeling tired, and always compare yourself to a couple months. I mean, are you able to do the same job without getting short of breath? But if you find yourself, you can walk 2 blocks now, you get tired, and they used to walk 8, 9 blocks, there is a problem. So the first thing is going to start a good history by your physician and a good physical exam. EKG, which is the electrocardiogram for the heart, a lot of time, it can give some information, but it's not diagnostic a lot of time. It can show you a scar of a heart attack that people have. And silent heart attack, it's not uncommon.
Let's talk about that, silent heart attack. I've heard, and a couple friends have had this happen and got to the emergency room, and they said, you had a heart attack, and they said, it happened to my brother-in-law, and they had no idea.
Well, the silent heart attack, it's very common. We see it a lot of time in older people. We see it in diabetic in particular because of the pain sensation. Now, a lot of those patients, they did have some symptoms. They have some discomfort, they have some nausea, they have some vomiting, they thought they have some viral symptoms, and they stayed at home. They didn't go to the hospital. And they were lucky to survive it. So a lot of time, when you do the EKG, it can show you a sign of an old heart attack. And the body is very interesting because if you have a blockage in one of the arteries and it happens gradual, your body senses that. So it builds what we call detours or collaterals, which is tiny blood vessels that go around the blockage. So
it builds that on its own?
It builds that, absolutely. So when the main artery shut down completely, that those detours or those side branches prop up. So that's why sometimes we have people that they have completely occluded one of the arteries for the heart, but their body already bypassed it. So those patients, if they're not having much symptoms, they don't need anything done because your body already bypassed that. So
that's the body really just sort of taking care of itself?
Absolutely. Absolutely. You get some patients in their 70s and 80s, they come in and you do the cardiac catheterization on them and they have 2 out of 3 or 3 out of 3 completely occluded and they just have some collateral or detours. So you need to talk with your physician. You need to have a good exam and a good follow-up. And the fact that you had a heart attack, which is very common, and you get your stent and you get your medicine and you're on your way, you need to have a regular follow-up because heart disease is a progressive thing. So most patients, when they come in with a heart attack, you have to understand that down the line, you're going to have more blockages, and down the line, you might need open heart surgery. So the more vigilant you are, the more compliant with your medicine, the more we keep your numbers at goal. So the two numbers that I'm going to throw,
Okay.
So the bad cholesterol. So somebody with heart disease, their bad cholesterol or their LDL should be less than 70.
Less than 70.
Yes.
The bad cholesterol, less than 70.
Yes. And the other number, which also as important, is for diabetic patients. That's called hemoglobin A1C, and that should be less than 6.5.
Hemoglobin A1C.
Yes.
Okay. And so what about high blood pressure or blood pressure? Because it vacillates from 120 to 180. It went up. Where should we, what's a good comfortable place that's not ridiculous?
Well, the blood pressure is a very common problem, especially with our Louisiana diet, which is high in salt. So 95% of the patient with high blood pressure, they have family history of hypertension. There is only about 5% they will have high blood pressure because of some other reason. So the majority of people, they have hypertension that runs in families. And management of blood pressure, most patients, they will have problem when their blood pressure fluctuates like what you said, when it has what we call peaks and valleys.
Right.
So the main thing is going to be you need to monitor your blood pressure, and you need to be on the right medicine to make the blood pressure steady. And when you get your right regimen, you stick with that. And every couple of years, you'll see patients that their blood pressure has been controlled. All of a sudden, they fluctuate a little bit. Could be related to some stress, could be related to some diet, and could be related to some weight loss. And by the way, if somebody has high blood pressure and they lose a lot of weight, you better watch out for your blood pressure because the blood pressure is going to drop dramatically.
Wow. So much more to talk about. We're out of time for now, but Dr. Meadaa, we've got to have you come back because there's so many other questions and concerns, and we want to make sure that people know what to look for and that they are able to advocate when they come to the doctor's office for themselves.
Thank you so much. I'll be happy to.
Indeed. Hey, everybody, stay on point. We're back after this. Welcome back, everybody, to the OPT Network. This is the final point on point today. We want to thank our guest this morning, Dr. Reymond Meadaa, for really breaking down our heart health and our heart issues in a very simplistic way so that every person can understand. Here's what we know for sure. Heart disease is the #1 killer of women. And I think that we stress that it's the #1 killer of women because it is often overlooked in women, because our symptoms don't always mimic that of our male counterpart. Our symptoms can be very innocent and very unassuming. That's why we do shows like this, because we want every person. Not only is it the #1 killer of women, it's the #1 killer of people, but we want every person to be their own best advocate. The only way that you can do that is through the power of information and knowing what to look for. Just a few months ago, my sister was having shortness of breath, and we knew that something wasn't right. She had been having shortness of breath for quite some time, but she overlooked it and she ignored it. And so at our insistence, we said, you know what? You need to have this checked. So we sent her to Dr. Gary Jones. Not only is Dr. Gary Jones a friend and contributor of the show, he is a friend of our family. And he said, you need to go see Dr. Meadaa and get it checked out because my mother has a history of blockage and heart disease. And so did my father. So she went in and he went through all the preliminaries and he sits you down and he takes all the time that you need to go through your history, to help you to understand what's going on and to ask you those very pointed questions that could save your life. So he said, we need to do a stress test. And they did. And then the stress test came back inconclusive. So he went to the next step and she had a heart cath. Well, when she came out, he said to us, your sister is very lucky. She had 95% blockage in the widowmaker, which could have killed her instantly. So I said to her, I said, Sissy, you are blessed. With tears in my eyes, I said, you are so blessed. I said, you had 95% blockage in your widowmaker. She didn't even know what the widowmaker was, because if you don't have a history and an understanding of heart attacks and heart disease, you don't even know what that is. And she just said, wow, I'm very grateful. I'm grateful to be here. And then he told us how much pressure he had to use to blow the balloon up that he put in her heart to open up that valve. And I'm telling you, that's just how quickly things can happen. And that's how quickly we could lose our lives and never be the wiser. So when we bring on people to talk about what's happening in our physical bodies, we all need to take note. Now, I don't know if you all saw Susan Lucci for Heart Month. Well, she too was talking about how lucky she was. I'm going to tell you, if you think you have a problem and you're not sure, you need to make an appointment with your doctor, and preferably your cardiologist. Anytime you say to somebody that you're having shortness of breath, for women, we put it off. We say, well, I've gained a little extra weight, or, we make every excuse in the world. What we are finding now, and statistics are showing, are that women are having heart attacks earlier and earlier. It's never too soon to start to ask questions and check on your heart health, especially if you have any of the risk factors that Dr. Meadaa spoke of today. If you have high blood pressure, if you have a family history, if you have high cholesterol, if you are overweight, these are questions that you need to be asking your doctor. You need to make sure that your doctor is running a blood panel that gives a story of what's going on in your body. And I said to Dr. Meadaa during the interview, with cholesterol, high cholesterol, it doesn't hurt until you have an event. And so you'll never know unless something like a heart attack or a stroke happens. The reason why we pound home this information is because no person should have to have a stroke or a heart attack. When we are armed with information, we are more powerful. But we've got to go get checked. We've got to do the work. The only person who can do that work for you is you. So knowledge is power. You got it today. Be powerful and use it. We're out of time for now. This has been the final point on Point today. Stay with us. We're back to wrap up after this.